Good evening. My name is Angela Golden, and welcome to Pulmonary Hypertension Association's PHA Live. Today's topic is PH and HHT, Signs, Symptoms, and Disease Management. We're so excited to have you here tonight. We'd like to thank Janssen Pharmaceuticals for their diamond level support of PHA Connects 2022. Thank you, Janssen. And following the presentation, you can use your Q&A button to submit questions. We will read those questions aloud to the speakers at the end of the presentation. And now let's meet our speakers. On today's call, we have leading the call, Dr. Murali Chakinala, who is a professor in the Department of Internal Medicine and co-director of the HHT Center at the Washington University School of Medicine in St. Louis, Missouri. And joining Dr. Chakinala is Jenna Olitsky and Nita Pai, who are PH and HHT patients. We would also like to recognize Cure HHT, who is partnering with Pulmonary Hypertension Association to bring this live to you tonight. Joining us as a moderator is Nicole Schaefer, who is the Director of Professional and Medical Programs. So thank you for joining us. I will turn it over to Dr. Chakinala. And while we do have a poll for you guys, you will be able to answer, and that should start shortly.
Good evening. I'm Murali Chakinala, and as the announcements were made earlier, I am a pulmonologist at Washington University in St. Louis, Missouri, and I'm thrilled to be here talking to the audience. I have two professional passions, and those are PH and HHT. I'm lucky enough to be able to lead both of our efforts at Washington University and collaborate a lot with both of these wonderful organizations, PHA and Cure HHT. So I can't think of a better use of my time than to share with you some insights into this important topic and help further everyone's knowledge of pulmonary hypertension in the context of HHT. So the format we have for you tonight is that we're going to spend the first 15 to 20 minutes just kind of getting an overview of the topic. I want to introduce to you what these entities are, why do we talk about them in the same breath, and then explain a little bit how they present, how they are evaluated, and then how they're managed. And then I think the best part of today is to actually hear from some patients, your peers, who have these diagnoses and how it's affected them and how they're doing. And then we'll end it with some questions later on. So to introduce everybody to the topic, we need to first understand a little bit of anatomy and physiology. This cartoon shows the thorax, or the middle part of your body, and of course in there are your heart and lungs. Your heart is right in the middle and your lungs are on either side. And it's important to understand this intimate relationship of these two organs because they're really partners and work together. And to further explain this, we have to delve into the heart itself. And if you cut through the heart and see what it looks like on the inside, you'll see something like this, where this is the right side of the heart shown in blue, and this is the left side of the heart right next to it. Notice though that even though it's one organ, there's a wall, a barrier between the two sides, and it's important that that barrier is maintained. So essentially there's a right side of the heart and then there's a left side of the heart, and they each have their own respective roles. And each side of the heart works with its own circulatory system. The systemic circulation is the blood flow to all over your body. And this is the job of the left side of the heart, to pump the blood through the systemic circulation. And its job really is to deliver oxygen-rich blood to all your other vital organs, your brain, your kidneys, your liver, everything else. There's a lot of resistance to that flow, but the left side of the heart is conditioned to take care of that. It can pump blood effectively and still maintain adequate pressures, even though the resistance is increased. Meanwhile, the lung or the pulmonary circulation is what the right side of the heart works with. And its sole job is to deliver the blood to the lungs. This blood is low in oxygen, and once it gets to the lungs, oxygen gets into the bloodstream and then returns to the left side of the heart for it to get pumped to the systemic circulation. Unlike the systemic circulation, the lungs, the circuit has very little resistance. Blood easily passes through the lungs, and so the right ventricle has a much easier job. It doesn't have to work as hard normally. And when it goes awry, you develop what we call right heart failure. Whereas, again, if most commonly we see problems in the left side of the heart, people develop left-sided heart failure. And you might often hear the term congestive heart failure, which is a very generic term, but most often when we say that term, we're talking about left-sided heart failure. So what is the purpose of the heart and the lungs? I mean, they have a lot of different roles, but at their core, their job is to make sure that our body is getting enough oxygen, all our tissues and our organs. So in order to do that, we think of something called oxygen delivery. How much oxygen are we delivering to all the end places in your body? And that's determined by several things. First off is how much oxygen actually gets dissolved in your blood after you breathe it in through your lungs. And then oxygen has to be carried throughout the bloodstream to the organs, and that's the job of hemoglobin. And then finally, in order for the circuit to work, you need a pump, and that's the heart. And we measure that in something called the cardiac output. And all three of these things, when they're right, then the system works very well. But when something goes wrong, like you have lung disease and your oxygen levels are low, or you're anemic and your hemoglobin gets low, or you develop heart failure and your cardiac output goes down, the other arms of the system try to take up the slack. So if your oxygen level's low, you tend to have higher levels of hemoglobin. If your hemoglobin gets low, the cardiac output is increased. So keep that in mind. These three things work together to make sure we deliver enough oxygen to our bodies. So let's talk about two entities clinical when things go wrong, and that's heart failure. And again, most commonly, that's left-sided heart failure. And that's a generic term, which simply means it's the heart is unable to meet the metabolic demands of the body. In other words, our body needs so much oxygen, and if the heart can't deliver that, then in essence, it's heart failure. And so we have a mismatch between supply and demand. And there are many ways that heart failure can develop. Most commonly out there, or the two most common ways I should say, is that the pump gets weak, like if people who've had heart attacks, for instance, the pump just doesn't work right. Another burgeoning way of heart failure is where the heart doesn't relax properly and the blood can't get into the heart before it can pump it out. But what we're really interested in today is something unique called high output heart failure, which is something HHT patients can get. And that's where the demands that the body puts on the heart can't be met by what the heart can supply. So it's not that the heart's failing necessarily at its job, it just can't work hard enough for a constantly stressed system, and we'll talk about why that is. Now, the other important entity that we're focusing on today is pulmonary hypertension. And I think most of you on this call today are on it because either you've been told you have pulmonary hypertension or you might worry that you have pulmonary hypertension because you have HHT. And at the crux of pulmonary hypertension is the fact that the pressures in the blood vessels of the lungs is higher than it should be. Remember how I told you that the resistance in the pulmonary circuit is very low? Well, because of that, the pressures are very low. But if the pressures are high, then you develop pulmonary hypertension, and it can limit how the blood is transported through the lungs, and it increases the workload on the right side of the heart, whose job is to pump the blood through the lungs. So again, it impairs the flow of blood from the heart to the lungs, and thus it limits how much oxygen that you're actually able to utilize, even if you're breathing it into your lungs. And pulmonary hypertension is commonly seen in heart disease, including left-sided heart failure. But the one type of pulmonary hypertension we particularly worry about is something called pulmonary arterial hypertension, which thankfully is very rare and a severe form of lung disease that we'll talk more about. So those two entities, high output heart failure and pulmonary hypertension, are the two conditions or disorders that we're really focusing on today. And why do HHT patients develop high output heart failure? Well, now I need to introduce another organ to you, and that's the liver. Again, here are your lungs on either side of the heart, and just below the diaphragm in your abdominal cavity is the largest organ there, and that's the liver right here. It's important to realize how the liver sits right next to the heart. They're neighbors, essentially. And the liver usually sends blood back to the heart, and normally it's not a problem. But what happens in HHT is that about 70% of HHT patients have some vascular anomalies or arterial venous malformations in the liver itself. It's much more common in the patients who have ALK1 mutations or HHT2. Now, even though it's common to have them, there's only a fraction of patients who actually get problems or develop symptoms from these AVMs in the liver. And by far and away, the most common manifestation is that high output heart failure that we talked about. And the reason is that because of all these malformations, here's a CT scan, and all these white spots in the liver are these malformations where the arteries and the veins are connected in an abnormal way. But the net upshot of these connections is that the blood returns to the heart much faster than it should. So let's delve into that a little bit more. Here's a simple cartoon. Here's the liver, and here's the heart up here. Blood comes to the liver through the hepatic artery, and then it goes through what's called a sinusoid. That's kind of the guts of the heart, the liver, excuse me. And here's a drawing of that where the blood comes in through this artery and has to make its way through these channels to the vein in the center, and that's this vein right here. Well, normally as that happens, the flow of blood is slowed down, and that's natural, and that's the way it should be. But in HHT, you can develop these arteriovenous malformations where there's a direct connection from the artery to the vein, and that blood doesn't have to go through that sinusoid. That sinusoid is like the stop sign, and if you don't have the stop sign, you can just run right through the light. Well, of course, you're going to go fast, and the blood is now going to get back to the vein, and if it gets back to the vein, it gets back to the heart too quickly. And so the heart has to receive all this extra blood all the time, and therefore it develops heart failure. And that can have other consequences, as if the blood bypasses through this, it doesn't go to the other areas of the liver like it should, and those areas can be deprived of blood. So typically we define high output heart failure by noting that measure, the cardiac output, is high, and there's a derivative of it called the cardiac index. Normally that should be less than 4 liters per minute per meter squared, but when the blood's rushing back to the heart too quickly, like in liver AVMs, that number can be much higher. And one of the things that can aggravate that is something that HHT patients commonly have, and that's anemia. Remember how I told you if something in that system goes down, like the hemoglobin, something else compensates? Well, that's the heart trying to compensate for the anemia by just pumping faster and increasing the output. When all this is happening in HHT patients, the heart is able to compensate by increasing in size and increasing the amount of blood and red blood cells and oxygen that it's going to pump with each single heartbeat. Eventually, it starts racing faster too, again, in order to make sure there's enough oxygen delivered to the tissue, but also to process all that extra blood that's coming back from the liver because of those AVMs. Well, that process is going to be taking place every minute of the day, and over months and years, the heart gets fatigued and it develops heart failure or high output heart failure. So what do patients feel? The most common symptom is they get fatigue. It's like they're running a race all the time, and eventually, you're going to get tired. Shortness of breath can be a problem. You have decreased ability to exercise. Patients often report palpitations, like they can feel their heart beat hard or heavy. And then if they develop arrhythmias like atrial fibrillation, then it's really noticeable. And then in the late stages, they develop heart failure with swelling in the legs and in the belly. Now, shifting gears to pulmonary arterial hypertension, thankfully, this is a rare progressive blood vessel disorder due to damage to the arteries, the small arteries of the lungs. So this is a problem that starts in the lungs, not in the heart like we were just talking about. Again, our patients with ALK1 mutations or HHT are much more likely to develop PAH as opposed to the patients who have other mutations like endoglin. The average age of HHT patients that develop PAH is about 22, and sometimes the PAH develops before the HHT manifests itself, so a PAH patient may not even know they have HHT. The symptoms are somewhat similar to high output heart failure, but shortness of breath tends to be the first presenting symptom. But as time goes on, people can again feel fatigued and decreased exercise capacity, and they can even pass out if they overdo it. They can also develop swelling in their legs and abdomen, and sometimes even get chest pain. So there's a lot of overlap in the symptoms. Later stages, the symptoms can distinguish themselves, but this is what makes it tricky to understand which problem is going on. Do you have pulmonary arterial hypertension, or do you have pulmonary hypertension due to high output heart failure related to your liver? So the arteries of the lungs normally look like this. There's very thin wall, and the center of the artery, this white space, is wide open, so you can easily get blood to flow through. But in PAH, all the arteries get very thickened, the walls get thickened, and the center, the lumen, gets very narrowed, as you can see with all these bizarre examples. And you can imagine when this happens, the resistance goes up, and it makes it harder for the heart to pump the blood through the arteries. And then when patients with pulmonary arterial hypertension progress and develop heart failure, now this is called right-sided heart failure, which again is less common than left-sided heart failure. And again, it's typically because of pulmonary hypertension, even if you don't have any other lung problems. Well, how do we diagnose pulmonary hypertension and really high output heart failure? It's through what's called a heart catheterization. And many of you have heard of this procedure. This is the catheter. It's very flexible. It's very thin and small. There's a balloon on the end of it. A doctor or a cardiologist typically introduces the catheter in a main vein in the body, usually in the leg or the neck. And then once the catheter is introduced into the vein, they inflate the balloon, and the balloon helps pass the catheter all the way up the vein from either the leg or the neck into the heart, as shown here. And then it goes to the right side of the heart, out the pulmonary artery, and stops right here. All along the way, the proceduralist can measure the pressures in the different chambers of the heart, and then ultimately in the pulmonary artery. And they can even estimate the pressures downstream of this in the left side of the heart by blowing up the balloon and stopping the flow of blood temporarily through one segment. It sounds scary, but it's a very commonly done procedure. Most patients are wide awake through it and don't feel anything. But it's really important to do that catheterization because that's how we make an official diagnosis. Well, how common is pulmonary hypertension in HHT? Our friends in the Netherlands showed that if you look at all HHT patients, about 14%, which is 1 in 7 patients, can have pulmonary hypertension. The prevalence is higher in HHT2, where it's up to 18%. So HHT patients are more likely than HHT1. The biggest risk factor for having pulmonary hypertension are the presence of liver AVMs, and the most common cause of pulmonary hypertension in HHT are these high output situations where people can develop high output heart failure. Well, how do we treat the high output heart failure? Well, we first want to recognize there are stressors, or the other things that can precipitate the heart failure, such as severe anemia from the bleeding that HHT patients can have, especially if they become iron deficient. If they develop arrhythmias like atrial fibrillation or atrial flutter or SVT, that can induce heart failure. If they develop other heart problems like their valves become too leaky, or they have lack of blood flow to the heart muscle through a heart attack, that can also cause heart failure. And the way we manage heart failure in HHT is a lot like how we manage heart failure in other cases of congestive heart failure. We use diuretics, medications that help you pee more, make more urine to get the extra fluid out of your body, particularly out of the lungs. We want to treat the anemia, so we do everything we can to control bleeding related to HHT in the nose and in the GI tract. And we should transfuse blood to avoid severe anemia. And most importantly, you got to take lots of iron, whether it's pill or an IV, to treat the anemia. If you have heart rhythm problems, you fix those heart rhythms. And then sometimes heart failure medicines can sometimes be tried as well. But we're in a new age now where everything is about these drugs we call anti-angiogenic drugs. And there's a drug called bevacizumab, known commercially as Avastin, and that can work really well to control bleeding, and in some people can really help shrink the AVMs in the liver so that we decrease the blood flow. It's like we're tapping the brakes on all that blood getting back to the heart too quickly. There are some other drugs in development like pazopanib that might also help, but it's too early to say. Ultimately, the patients who are the sickest may need a liver transplant. And a liver transplant removes the root cause of the problem, which is to get rid of those AVMs. Now the heart can rest. And it can also prevent other complications of liver AVMs, like where the bile ducts in your liver don't get enough blood flow because it's all going quickly to the heart, or you can get confusion or encephalopathy. But certainly transplant comes with risk of the surgery and then afterwards being on immunosuppressive drugs. So we don't like to play that card unless we really don't have any other options. Now, pulmonary arterial hypertension treatment is very different. We have lots of medications for treating the blood vessels in the lungs, and this table shows all the different drugs. We have a bunch of oral medications, we have inhaled therapies, and we have continuous infusion-based therapies. All these drugs work really well for PAH, and in selective cases of HHT with pulmonary arterial hypertension, we can use them, but it can be very challenging. The benefits of treatment are to decrease the shortness of breath and fatigue, to improve your exercise capacity, hopefully improve your quality of life, decrease the rate of decline, meaning getting worse, developing heart failure, and then hopefully helping you live longer. And I think it can in many cases. Now, there are challenges to PAH therapy in HHT patients. Unfortunately, some of these medications can increase bleeding because of the effect that the medicines have on platelets. They can also increase cardiac output, and that means more blood flow going through the little telangiectasias in your nose and in your GI tract, so bleeding could increase for that reason. And then if you're on infusion therapy, if your catheter gets infected, that could be a bad deal because bloodstream infections from a catheter increase the workload on the heart even more, and that won't be well tolerated in HHT. And then HHT patients can also develop AVMs in their lungs, and those can pose challenges when you also have pulmonary hypertension. And so these kind of very complex issues really require that if you're one of those rare HHT patients who also has PAH in particular, you should be managed jointly by your HHT team and a PH team. So to summarize, we're dealing with two important entities here, high output heart failure and pulmonary arterial hypertension. In high output heart failure, you can develop mild pulmonary hypertension, but it's not the main problem. The symptoms in particular are fatigue and palpitations, and you develop heart failure involving the left side of the heart. Much more common in ALK1. In older patients, people can still live a long time, and our general treatments are heart failure medications, and now we're learning to use anti-angiogenic therapies like bevacizumab. And then in extreme cases, it's liver transplantation. In PAH, which is very rare, the problem is the pulmonary hypertension, and the biggest symptom is shortness of breath. And when it advances, you develop right-sided heart failure. It's also more common in ALK1, but endocrine patients can get it too. Tends to affect younger people. Unfortunately, life expectancy historically hasn't been as great, but we're making progress with all our therapies. And the treatment or mainstay is really pulmonary vasodilators and also diuretics. And then lastly, or at the end stage, we would consider a lung transplant. So that was a real introduction, a crash course, if you will, on these conditions. And I hope that was helpful for all of you, and I'll be happy to take some questions at the end. But I think before we do that, we have a really special segment here. And so I want to turn it over, or introduce to you a very special young lady who I have the privilege of taking care of. Her name is Jenna Olitsky. Jenna is joining us from the West Coast. Jenna, if you want to turn your screen, there we go. So Jenna's going to take a few minutes, I think, first to just introduce herself and tell you a little bit about her journey of, both HHT and pulmonary arterial hypertension.
Thank you. Like you said, I'm Jenna Olitsky. I am right now in Orange County, California. I am both an HHT patient and a pulmonary arterial hypertension patient, one of those rare ones that you were talking about. I hope by sharing my diagnosis story that you can see similar signs or symptoms, and if you have one or the other, that you can see some of the similarities to my story. So I'll start with my HHT diagnosis. I think it's a little bit more unique than some others. I've known about HHT in my family for generations. I think we've mapped it back about 3 generations. I, as a child, had no outward symptoms. So I was genetically tested as a preteen. I had some typical signs, like I would have occasional nosebleeds, but really, other than that and some red dots, no outward signs, but kept getting tested. I do have the ALK1 gene mutation. So with that, I always knew HHT was in my family. I have sisters who have it. It runs through my father's side. I have multiple cousins and uncles and aunts who have it. So it's always been a part of our lives. But PAH and PH was not. So I think that side of my diagnosis history is a little more common with some other people that I didn't know the signs of it. And looking back, some things kind of made more sense. Once I did get a diagnosis, I did have, the typical signs of shortness of breath, passing out, but they all kind of made sense in certain circumstances. So I didn't put a lot of weight into it. And really my PAH diagnosis journey started in 2016. I was, in my mind, healthy. I was running, half marathons, doing spin classes, yoga classes. Didn't think anything of it, but going upstairs or hills were very hard for me. I would feel shortness of breath. I would feel like I was going to pass out. Sometimes I did pass out, and I knew something wasn't completely right there. And so I started, I think after there was one episode where I was walking up a flight of stairs and I passed out, which after all those other activities wouldn't make any sense, that I started to see an internist to see, what's going on here. And, they noticed I had a high heart rate. They noticed I was, out of breath, but they kind of just blew it off, which in my mind, I was like, maybe that could be right, but this kept happening. And so I went and got a second opinion, and I wore a heart monitor for a week and did normal activities. Nothing popped up. I still exercised. I was still doing everything normal, but none of those episodes had happened, so we couldn't figure it out. I then went to a cardiologist who tried to get me a bubble echo, and I'm sure many of us have had those, and I tried to get one, but my insurance wouldn't accept the testing for it based on my previous non-diagnosis by an internist. So I was kind of in a bind. I didn't know. Luckily, through my family's persistence and my cardiologist's persistence, I finally got a bubble echo the day before I was supposed to leave for a trip, or the day of leaving for a trip. So I went in, I got my bubble echo. I went to go pack as normal. I got a phone call that there was something abnormal with my testing, that there was some higher pressure, but based on, bubble echo, we wanted to do more testing. So Dr. Chakinala had said, I went in for a right heart catheterization, and that's kind of when my formal diagnosis of pulmonary arterial hypertension had occurred. I do have the telltale signs of shortness of breath, you know, passing out, not as much anymore, but of walking upstairs. You know, there's some heart palpitations, but, you know, like I said, looking back, I could see some of these things, but I would say, you know, this was altitude, this is being tired, but those little signs kind of all added up. So in 2018, I got my formal diagnosis of pulmonary arterial hypertension, and I started therapies for that. I'm on oral therapies, like we were talking about, diuretics. I'm on a subcutaneous pump. I had to do a lifestyle change for disease management, which has been working so far, like a low sodium diet, exercising in moderation, but with caution, as many people probably do. And it's just really, you have to change a lot of what you do for it, but, you know, it does work. And even with both diagnoses, I live a normal life. I work full time. I travel. And so it's more about knowing yourself and knowing what your symptoms are and knowing the signs, and also just being a big advocate for yourself. So that's kind of my story.
Thanks, Jenna. You know, first let me just say I think Jenna's story is really remarkable because of the kind of person she is, and despite having these problems, what she's already accomplished in her life and how full it is, it's really inspiring. I mean, she finished law school, she works, she travels. I mean, it's just really a testament to her character. And I think the other thing I would just say also for some of the people in the audience, you know, Jenna's lucky because she's from such a great family who is well aware of HHT. Because if she didn't know that in the family history and a doctor didn't know that, they might have just diagnosed her with idiopathic pulmonary arterial hypertension because she really didn't exhibit much in the way of HHT when we found her PAH. And I've heard this from my colleagues around the world sometimes, that one of their patients with who had idiopathic pulmonary arterial hypertension and started having a lot of problems with nosebleeds. And then we dug into it, and lo and behold, they actually had HHT. I see a question in the chat already about this, you know, about if I have IPAH or idiopathic, how would I know if I have HHT? Well, I mean, the easy way is to get genetic testing done, which is available for PAH patients. And the two of the genes that are in the gene panel for PAH are the HHT related genes, but we don't utilize the gene testing that much in PAH. So the other way for people to know is if you are exhibiting other symptoms like nosebleeds primarily, that would be the #1 reason or #1 clue that you might actually have HHT. So if you're a PAH patient and have a lot of nosebleeds, doesn't mean for sure you have HHT, but it's important to bring that up with your doctor and let them decide, is there something really here or not? I'd like to introduce our next patient speaker today. And Ms. Pai, if you want to turn on your video screen. Hello there.
Hi, Dr.
Hi there.
Chakinala. How are you?
Good, good. I'm Dr. Chakinala. So obviously we've never met before. So
I've seen you at conferences.
oh, great. Well, thank you for joining us tonight. So maybe you could take a few minutes to tell us your story, much like Jenna did with hers.
Do you just want the story, or you want me to talk the whole thing that I came prepared?
You know, maybe we want to try to have some time for questions for the audience. So it's like 7 past. So maybe if you could talk like 5 to 7 minutes and give us a little bit of your story of how your journey played out and what have been the big lessons you've learned from going through this.
Okay, sounds good.
Thank you.
Hi. I too am diagnosed with PAH and HHT. But what's different about me is that I was diagnosed first with PH before HHT. PH took 9 years at least from my first noticing breathlessness. I was treated with for asthma, and then I went for second and third opinions, and they both unanimously agreed that it was asthma. So as time passed, though, I was unable to run, jog, and then finally couldn't even walk with my dog that I enjoyed since 1983. All these activities I used to do with no issues. And if I continue to do these things, I would have syncope, just like Dr. Chakinala explained. By the time I couldn't even walk 50 feet without turning blue in the lips, knuckles, fingertips, and cuticles. And my PCP that I went to couldn't figure out what was wrong with me. And cardiologist was perplexed because she couldn't understand why this was happening when my heart was in perfect condition and my whole body was so fit with no fat or anything. And I was a problem for them. So they kept postponing my appointments. When the nosebleed started, and then it was written off to dry air living in, New York area. So I felt like I was going to die in a week. The situation was so dire for me that I started to make phone calls to our physician friends as a last ditch effort for a diagnosis. I said, at least let me know what I had. And a cardiothoracic surgeon friend suggested that my cardiologist perform a right heart catheterization. So this is how I got diagnosed with extremely high lung pressures and was placed on Tracheal. That is the only pill form of FDA-approved drug for PH in 2004. But I refused to get on 24/7 IV in Flolan, wishing for a natural death instead. I was afraid of infections and its 30-minute shelf life, a half-life, I'm sorry. As the medications in the delivery system improved for PH, the nosebleeds increased in severity and frequencies for me. So I went and saw many ENTs, but none of them had any answers, except that I was told to get off the PH drugs, which my PH specialist refused to do. I was referred to Mayo Clinic by her. We saw a PH specialist there and an ENT who found telangiectasia in the nose. And this was in 2007. However, nobody knew what was the outcome and what could be done. The pulmonologist, HHT specialist I was referred to said, well, you're on right track. There's no other treatment for you. And in 2009, my PH specialist at Mayo Clinic suspected HHT and ran a number of tests to scan the organs. He did MRIs and CAT scans, and he discovered AVMs on my liver. So now I was clinically diagnosed with HHT, and the HHT specialist treated me, genetically tested, and the genetic test results didn't give me a straight yay or nay. Until recently, when more genetic malformations were discovered in Salt Lake City's research. So interestingly, like Dr. Chakinala was explaining, I do have PAH with HHT. And after my diagnosis, recently my daughter took her child, asking the pediatrician to see if her daughter had it, because I was insisting on it. And all they did was a pulse oxy test, and under a minute, and they said, no, she's fine. She's so active. Yeah, she is active. We knew that. But why does she have nosebleeds in living in humid Bay Area was my question. So they said, tell her to stop sticking her finger in her nostrils. End of the story, end of test. So I feel, interestingly, there's a lot more global awareness of PH now. However, in spite of the baby steps in HHT diagnosis and treatment, it is still unheard of, even in advanced countries like ours. Shockingly unknown is the fact that HHT may be linked to PH. Only now there's more awareness going on, thanks to the efforts of uh, PH Association and Cure HHT Foundation. So regarding treatment and living with these two diseases, I have two steps that help me stay cheerful and depression-free. As you know, all diseases, especially the rare ones and chronic ones, cause depression. So for me, if I pay attention to self-care and also community care, I'm happy. So the both pH and HHT are stabilized in my body. Reducing the lung pressure to closer to normal has not occurred. By the way, I'm alive last 17 plus years. It'll be 18 in September. So as Dr. Chakinala explained, the balancing the treatment of pH to not allow internal bleeds and bleeds from the nose to not start is a major effort and a challenge for my pH specialist. This is why I highly recommend only being treated by a specialist at a PH and or HHT center. I'm on IV Avastin infusion, Avastin treatment for HHT since May of 2014. Thanks to the current HHT specialist at Mayo Clinic, who enrolled me in a research that he led, and I have no bleeds. They've completely stopped. Keep in mind, it's not just Avastin that has done this. It's also the self-care that got me to this stage. I religiously do my sinus rinses twice a day, followed by moisturizers. I avoid the strong sun, get off the sun just when the body gives the first warning sign, because the pH drugs that vasodilate can pop from further dilation of the sun, from the sun. Take my pH drugs on time with an alarm. And I'm also very proactive to regularly schedule my Avastin treatments, and I do my best to learn all about the disease. I ask questions and my doctors explain it to me. So everything I ask my doctor, and every T has a dash and every I has a dot, and I follow that. We have traveled a lot via cruise ships until COVID hit our country. That's all due thanks to my PH and HT specialist at Mayo and a very supportive, positive thinking husband who loves to cruise. It's also very important to learn all that we can about the diseases. So we are the best advocates for ourselves when we have to educate and deal with the ER staff for the next bleed that you may encounter. My new first year ENT residents, I used to say, some of them it was first day for them or the sixth day. So they would see the bleeding, the blood gushing out of the nose, and I could see the fear in their eyes. So I would say to them, I know what works best for my body to stop the bleed, and you have the expertise and knowledge. So let's work together as a team. And it always worked. The second step is for our mental and psychological health, strengthened by faith in a higher power within you, or religious or spiritual faith. One of the things I did as I was diagnosed and treated for PH was to write my story. All my emotions came forward and got me to come to terms with the situation. It helped me to get rid of the shock. I was plunged into not feeling any of the emotions. And one of the staff members of PHA read it and suggested I use it as an awareness spreading and funding campaign. My daughter cut it to a more readable letter, and I sent it via hundreds of contacts to work via email. And my neighbors, my friends, spiritual friends, to my circles, of other relatives, everybody. Money poured into PH Association, adding up to over $5,000, made me happy. Though a small amount for PHA, awareness was definitely achieved. Fast forward, one of my relatives was going through similar symptoms and they knew whom to seek for a quicker diagnosis. Eventually, this is what we all want, to be diagnosed in earlier stages, to be stabilized and the disease arrested, to return to some normalcy for a happy life. And that's what all our doctors want too, a happy life. And unfortunately, both these diseases have social isolation. PH with the lung pressures makes us short-tempered, lose concentration, ability to focus, unable to read, all these things you can name, and we have it. So this is where PH Association provided support for me with their message boards, support meetings, both in person and private patient-to-patient chats over toll-free calls. And these days, of course, there are many groups on social media. It's a huge relief to know you're not alone with this rare disease. And with HHT, nosebleeds in public cause such embarrassment, panic and anxiety when onlookers race to get away from you. So both these diseases make you unable to meet your friends on a set-up date or lunch or anything like that. So you are in a isolation from society. So who wants to be around us anyway? So faith in a higher power sure helps get us through. Keeping the focus on now, today, and treating the present as a gift, counting my blessings for being alive and for all the good things in my life helps me get through. And something that I have noticed with the HHT Foundation and PH Association is that HHT treatments have come a long way. It's easy to see how and why. These organizations manage the advocacy campaigns at country's capital for funding research trials that lead to better drugs via a simple delivery system and so on and so forth. So it's important to show that we patients live and deal with only through us for the associations. So we need to get involved and we need to join their advocacy efforts. And conferences are another proof where patients, doctors, research scientists, and pharmaceutical companies come together and registries are being conceived, followed up with studies, classifications and name changes required are accurately recognized through research, various PH forms as they're diagnosed based on causes, and so on and so forth. So Cure HHT Foundation is also following in similar steps, and we need a lot more member patients to register, use the resources to get educated for your own benefit, take part in research trials, etc. It's a struggle to stay afloat for these organizations, as well as us patients with such expensive PH treatment co-pays. The least we can do is make use of what is happening, what is given as information on the website and through their newsletters, register with them and watch the webinars that are educational, and of course pay our membership dues. So I'm sorry if I'm taking too much time, but I'm hoping that when everyone gets involved and a cure can be found, not just, if not for me, for the future younger generation. Thank you. I had to put that in.
You said a lot of great things there. I appreciate you advocating not just for yourself, but for the community and the organizations. Maybe we'll take a few minutes here just to try to answer some of these questions. I've been kind of monitoring the questions that have come in. I know some of you sent questions ahead of time and can try to maybe group some of these things together to also touch on some of the points you and Jenna made. So I think patients who have HHT are asking, well, how do I get diagnosed and how closely do I need to worry about this? Well, if you're an HHT patient, chances are you've already had the #1 test that would be helpful for picking up pulmonary hypertension, and that's an echocardiogram. Jenna pointed out the bubble echo that she had to go through to get, did struggle to get that test done, but that's what showed her pulmonary hypertension. So that's typically how we would detect pulmonary hypertension, is with the bubble, with an echo, and then we would do the right heart catheterization. How often do HHT patients need echoes? I wouldn't say that HHT patients need to have regular echoes just to look for pulmonary arterial hypertension, because it is pretty rare. Now, the patients who have liver AVMs, they need echoes periodically to look for high output heart failure and the onset of mild pulmonary hypertension. How often is really not clear, and it's individualized between the treatment team and the patient, and it really depends on the risk that you have for developing high output heart failure. So that's if you're HHT and how would you diagnose pulmonary hypertension. The flip side is patients are asking if they have PAH, how do they know if they have HHT? Well, as I kind of alluded to, if you're having any symptoms of it, most notably significant nosebleeds, or potentially the skin telangiectasias that can develop over time, those are clues that you might have HHT. But really a lot of it would be the family history. And then the way to make a diagnosis, which is another area I wanted to touch on, because genetic testing is available for both, but it's heavily used in HHT and not so much in PAH. And the reason for that is that because we can readily find the mutations for HHT, and the HHT genes have high penetrance, meaning that if you have a mutation that is linked with HHT, at some point in your life, HHT is going to express itself. So clinicians at HHT centers are readily utilizing genetic testing to make a diagnosis. The flip is the case in PAH. We have genetic testing available. There's now I've lost track, it's at least 12 different genes that can cause PAH. The HHT genes are a very small number of them. Most commonly, it's a gene in something called BMPR2. The reason we don't tend to do more genetic testing in PAH patients is it's complex, but one of them is that the penetrance is low, meaning that people can inherit a mutated gene but never develop pulmonary arterial hypertension. And so it becomes difficult to understand how to interpret that information. So I'm not discouraging anybody from going out there and getting the genetic test. It's just the answers aren't as straightforward in PAH like they are in HHT. One of the questions in the chat was that, well, if I have HHT, what is the chance I might get PAH even though I don't have a BMPR2 mutation? Well, that's really irrelevant, because an HHT patient doesn't get PAH because they have a BMPR2 mutation. It's because they have either ALK1 or endoglin, which is causing the HHT and can also in that individual cause PAH. There was another question in the chat about a family where the mother passed away from PAH. The person typing in apparently has both conditions. They want to know how likely is their child to get PAH and HHT. Well, let's assume that that child has the HHT gene. That doesn't necessarily mean that child is going to get PAH. As the HHT patients in the audience know, HHT expresses itself very differently from one member of the family to another. So just because a parent or a grandparent had PAH in an HHT family, it doesn't necessarily mean that the child is going to get it, but that I would definitely be on the lookout for it and make sure that the physician taking care of that child understands that you don't just have HHT, but you may also be at risk for developing PAH, probably more than the average HHT patient, and following echoes closely would be a good idea. So let me see what other questions there are that we can cover here in the last few minutes.
Dr. Chakinala, can you explain the distinction between HHT1 and HHT2?
Yeah, sure. It's a great question, Nicole. And this goes back to the genes. The two genes or common genes that cause HHT, are the endoglin gene and the ALK1 gene. endoglin mutation in it, again, causes HHT1, and those patients are more prone to getting AVMs in the lungs and the brain, less likely to get AVMs in the liver, and less likely to get either form of PH or PAH. ALK1 is what we associate with HHT2, and those patients are less likely to have lung AVMs and more likely to have liver AVMs, and also more likely to develop PAH, although the risk still remains pretty low. So it gets a little confusing, either one can cause PAH, but much more likely in the ALK1 patients. Nicole, do you have any other questions that maybe especially for the panelists, if any patients have something that they might want to answer?
No, I'm not seeing any specific to that, but I do think that they both really illustrated the importance of being connected to a community and to getting the care from HHT and the PH specialists. And I would say that there is some significant overlap in our HHT centers. I think there's at least 10 that have both of those specialties for individuals that do have both diseases.
Yep, I agree. I have a couple other quick ones maybe we can cover in the last couple minutes here. Once a diagnosis with HHT and PAH, like the two ladies on our panel has been made, is the treatment very different from other PAH patients who don't have HHT? And actually there are some differences, I think. While we have all these therapies for PAH, we have to be real careful because the PAH treatments can make people bleed more. I think maybe Ms. Pai mentioned that. So I know as a doctor who takes care of both, I'm a little more cautious with certain medicines that I readily use in non-HHT patients than I will in my HHT PAH patients. And some PAH patients are also put on blood thinners, which we really don't like to do in HHT. So that's another potential departure between the two. And then I see one other question here about, is it possible to have a lower than normal cardiac output with HHT and PAH? Because remember I mentioned HHT patients can develop a high cardiac output. And yes, absolutely. In fact, HHT PAH patients are more prone to developing heart failure because of low cardiac output. That increased resistance to blood flow in the lungs impairs how the right side of the heart works, and you develop a low output state and heart failure for different reasons. And that's why you might pass out if you overdo it, as opposed to the high output heart failure that other HHT patients develop because of the liver AVM. So that's a good question. So I see we're up at the end of the hour. I know there was lots of other questions here. I apologize we can't get to all of these. Some of these are really specific for individual patient recommendations. It's a little hard to answer those on this chat. I apologize, but you heard both from me and from your peers here how important, if you have both of these diagnoses, PH and HHT, to really be taken care of by somebody who's familiar with both. And in a lot of places, that's two different teams. So please, kind of direct your questions to those folks, as we just can't get to those kind of individual type topics on a webinar like this. Nicole, I think you had some parting words for us, and maybe even before that, I don't know if Jenna and Ms. Pai have anything else they want to say in the last few seconds for everybody.
I just want to say thank you for having me on here. It's a big passion of mine to share, awareness of both HHT and of PAH, and sharing how, even though you have both of these kind of rare diseases, that, you can have a fulfilled life no matter, with some cautions. And if you ever have any questions, I think my information is available and I'm more than happy to help out.
Thank you, Jenna.
If I may,
yeah.
I just want to stress that everyone please join PHA and Cure HHT I think PHA even allows you to join if you can't afford the membership. Join the registry so we have all the patients' names, and whatever help you can, focus your energies on that and get rid of your anger, grief. It really helps you with the advocacy or with the spreading awareness. And please advocate for yourself. You're the best advocate for yourself. Learn, educate
Very
yourself.
wise words.
Absolutely. Well, and I just want to again thank PHA for the partnership with Cure HHT. We are associated diseases, and we are really trying to reach out to both of our communities and educate on both diseases, since there is some relatedness there. And we can learn from each other. And for both organizations, we are only here for the patients and to support you, both in your diagnostic journey, with, you know, family questions, and as Nita said, to just know that you're not alone. So we appreciate everybody being here, and you know, reach out to either one of us if you have any questions or need referrals to any locations for care.
And Nicole, isn't there a Facebook group for PH and HHT patients?
There is. Angela, do you know the actual name of that group?
I don't have that information right on me, but if people would like to join that group, they can email simply phawebinars@PH Association, and we'll be able to assist you. I will make sure I can send that information out in the follow-up email, just to make sure that you're connected to that Facebook group as well. Thank you.
Yeah, and that's monitored by both organizations.
Yes.
So, you know, it really is more specific to individuals that do have both PH and HHT. But it's an opportunity for us to get information to that specific rare group of individuals as well.
Yes, absolutely. And like I said, I will put that information in the follow-up email to this webinar. I want to thank everyone for joining us tonight. This could have gone on for a whole other hour, but thank you for your expertise, Dr. Chakinala. Thank you, Jenna and Nita, and of course, Nicole. This partnership with Cure HHT was very important to us here at PHA, so we appreciate you giving your time this evening on this very important topic. Again, thank you to Janssen Pharmaceuticals for their diamond level sponsorship of this PHA Live event, and we'll see you next time. Thanks, everyone. Y'all have a great night.
Thanks, you too.
Bye.
Thank you.
Bye.